is one of our best performed procedures, the longest performed procedures, and I think one of the most successful, and has really changed very little since we started, except marked increase or improvement in the devices. It's first published in 1982 by Gene Kahn and Bob White at Johns Hopkins. As I say, it's one of the most successful of our, quote, definitive procedures. Initially, we were only doing pulmonary valves, isolated pure pulmonary valve stenosis. Pulmonary valve dilation was of the VACA registry, which I think most of you are familiar with, a registry, 27 centers back in the early 80s got together, voluntarily collaborated in collecting data on 6 different major procedures. This was non-funded, and we had, as I say, 27 centers, and in the pulmonary group had 822 patients. Criteria for pulmonary valvuloplasty, the signs, the typical signs of pulmonary valve stenosis, and it actually, you can probably make this diagnosis clinically before you go to the x-rays and EKGs, but very close to it just from the physical exam. Echo, thick doming valve, and the continuous wave Doppler. And unlike aortic stenosis, where there's a pretty good variability between the Doppler and the catheter gradient, there's excellent correlation when taken simultaneously with the catheter. So you can believe the continuous wave Doppler in pulmonary stenosis, and it probably gives you a better number than in the cath lab when the patient's sedated or anesthetized. So you get the awake patient. Pressure gradient in the cath lab, I think we've moved down to about 35 millimeters of mercury. I think nobody'd be critical if you went to 30 or you went, and certainly higher gradients. But you could get easily RV in a pulmonary artery curve along with femoral artery. Angiographic confirmation that you're dealing with pulmonary stenosis. Here you see a very, very tight valve in the AP and lateral, very typical. Technique, and I won't dwell on this a whole lot, just a few topics. I like the double valve technique.